Welcome to the first late-breaking clinical trial. As you can see from the way the stage is set up, this will be a little bit different than what we've seen before. Our presenters will be up on stage. Our panelists will be facing the presenters, as you can see, and we will have a little bit of a different interaction than you've seen in the past. As Dr. Kuvan said, make sure you download the app, the meeting app, onto your phone, because we are going to ask you some questions. You'll be able to respond to the questions via your phone. So this session is co-sponsored with the Journal of the American College of Cardiology, but this does not imply that the abstracts from this session will be published in JACC. Dr. Valentin Fuster, whom you all know, is my co-chair, and he will facilitate the discussion of the ODYSSEY trial. Our panelists for today are Dr. Sana Al-Khatib from Duke University, Pamela Morris, Medical University of South Carolina, Dr. Patrick T. O'Gara, Brigham and Women's Hospital, Dr. Sid Smith, UNC School of Medicine, and Dr. David Wilbur of Loyola University. And I'll turn the program over to you, Dr. Fuster.
Yes, thank you very much. It's really an honor to be part of this new format and to be moderating this first session. Before we start, let me entitle the session Cardiovascular Outcomes with Alirocumab after Acute Coronary Syndrome Results of the ODYSSEY Outcome Trial. I'd like to ask a question to the audience, and that is, with everything that you know about the PCSK9 inhibitors, see how would you answer this question? All right, here we are. The use is frequently, 1 per week, occasionally, infrequently, or I don't prescribe this medication at all. Too expensive. Anyway, yes, I prescribe maybe 1 per quarter, and you go to a struggle, as you all know. Let me see what happened with the next presentation and see if this is going to change our minds. It is a pleasure to introduce a very close friend, Dr. Philippe Steg, who is the head of cardiology at the Hôpital Bichat in France, and who is going to make the presentation of the ODYSSEY trial.
Thank you, Dr. Walsh, Dr. Fuster. Dr. Walsh, Dr. Fuster, ladies and gentlemen. I'm Gabriel Steg. I'm a cardiologist at Hôpital Bichat in Paris, France, and it's my privilege to present here on behalf of my colleagues, Dr. Greg Schwartz, my co-chair, and the investigators of the ODYSSEY Outcomes trial, the top-line results from ODYSSEY Outcomes investigating alirocumab in patients with ACS. I want to point out that these are truly the top-line results, and that the Executive Steering Committee saw the results for the first time 7 days ago. These are my disclosures. Residual risk after acute coronary syndromes remains high despite evidence-based preventive therapies. It's related in part to levels of low-density lipoproteins cholesterol. It's reduced when LDL is lowered by statin therapy compared with placebo, high intensity compared with moderate intensity statin therapy, and ezetimibe compared with placebo added to statin, although the latter two do not affect mortality. PCSK9 is a validated target for risk reduction in stable atherosclerotic cardiovascular disease. Alirocumab is a fully human monoclonal antibody against PCSK9, which produces substantial and sustained reductions in LDL cholesterol and other atherogenic lipoproteins. It's been safe and well tolerated in studies to date. The study hypothesis was that alirocumab versus placebo would reduce cardiovascular morbidity and mortality after recent ACS in patients with elevated levels of atherogenic lipoproteins despite intensive or maximum tolerated statin therapy. To be enrolled in the trial, patients had to fulfill 4 criteria: an age equal to or above 40 years, an ACS 1 to 12 months prior to enrollment, high-intensity statin therapy defined as the top 2 doses of atorvastatin or rosuvastatin, or maximum tolerated dose of one of these agents for at least 2 weeks. Patients who did not receive the top doses of the 2 statins had to have documentation of intolerance to at least 2 statins or documentation of biochemical abnormalities on statin therapy. Finally, they had to have inadequate control of lipids defined as any of the 3 following criteria: LDL cholesterol equal to or above 70, non-HDL equal to or above 100 milligrams per deciliter, and ApoB levels equal to or above 80 milligrams per deciliter. The key exclusion criteria are listed on this slide and include, among others, uncontrolled hypertension, advanced heart failure, history of hemorrhagic stroke. The primary efficacy outcome was a quadruple composite of coronary heart disease deaths, non-fatal MI, ischemic stroke, and unstable angina requiring admission, with very stringent criteria to define the latter. All outcomes were adjudicated by the Clinical Events Committee from DCRI, and members were unaware of treatment assignment of lipid levels. The main secondary efficacy endpoints were tested in the following hierarchical sequence: CHD events, CHD deaths, non-CHD events, major CHD events, CV events, the composite of deaths, MI, and ischemic stroke, CHD deaths, CV deaths, and finally, all-cause deaths. Other secondary endpoints included components of the primary outcome considered individually: ischemia-driven coronary vascularization, heart failure requiring hospitalization, adverse events, and selected laboratory assessments. Treatment assignment is depicted here. Patients with a recent ACS 1 to 12 months prior to enrollment entered a run-in period of 2 to 16 weeks on high-intensity or maximum tolerated dose of atorvastatin or rosuvastatin. During that period, they were also trained in self-injection. If they had at least 1 lipid entry criterion met at the end of that period, they could be randomized to placebo or alirocumab given every 2 weeks sub-Q. Patients and investigators remained blinded to treatment and lipid levels for the entire duration of the trial. The trial aimed to get patients into a target range. We started with patients with an undesirably high baseline LDL cholesterol above 70 milligrams per deciliter. Starting with a dose of 75 milligrams every 2 weeks, we wanted to get patients into a target range between 25 and 50 milligrams per deciliter LDL cholesterol. If that was not achieved, the dose could be increased in blinded fashion to 150 milligrams every 2 weeks. Patients between 15 and 25 remained in that range, which was deemed acceptable under additional safety monitoring, again in blinded fashion. Finally, patients who remained consistently at 2 consecutive measurements of LDL cholesterol below 15 milligrams per deciliter were down titrated, and if these patients were on 75 milligrams per deciliter alirocumab, they were blindly switched to placebo. All analyses were conducted by the independent academic statistical team at State University of New York Downstate School of Public Health in parallel with the sponsor statisticians. All efficacy analyses are by intention to treat. The main assumptions are summarized on this slide. We aimed for a 15% expected hazard reduction for the primary endpoint. Assuming a loss to follow-up at 24 months of 1%, 90% power, and a single-sided 2.5% significance level, We continued the trial until 1,613 patients at least had met a primary endpoint, and all surviving patients were followed for a minimum of 2 years in order to have adequate safety assessment. This was a global trial enrolling 18,924 patients at 1,315 sites in 57 countries. Enrollment started in November 2, 2012, and the common study end date was November 11, 2017. We thank the patients, their families, the investigators and coordinators involved in the study, and the Duke Clinical Research Institute. We could not have achieved such a trial without the support of superb national leaders from each participating country and the guidance of the Executive Steering Committee co-chaired by my colleague Dr. Greg Schwartz, the Clinical Events Committee led by Paolo Tricocci, and the Data Safety Monitoring Board chaired by Dr. Chaitman. Additionally, ODYSSEY Outcomes was an academic trial enrolling the support of several academic research organizations worldwide, which played a key role as an interface between the trial structure and the investigators. Finally, I want to recognize the extraordinary contribution of the independent statistical team of Michael Zarek at SUNY Downstate School of Public Health. Patient disposition is depicted here. We randomized 18,924 patients into 2 equal groups. Median follow-up was 2.8 years, and I point out that 44% of the patients had a potential eligible follow-up of 3 years or more. Premature treatment discontinuation was seen in 14.2% of the patients in alirocumab, 15.8% in the placebo arm. In addition, 7.7% of the patients in the alirocumab arm underwent a blinded switch to placebo because of 2 consecutive LDL cholesterol values below 15 milligrams per deciliter. Follow-up was outstanding. The absolute number of patients lost to follow-up for vital status was 14 in the alirocumab arm, 9 in the placebo arm. The demographics are as expected for an ACS population with a median age of 58, 25% of the patients being female, and an expected distribution of common risk factors. The time between the index ACS and randomization was a median 2.6 months. Approximately half of the ACS were non-STEMIs, 35% STEMIs, 16 to 17% unstable angina. More than 70% of the patients underwent revascularization for the index ACS. The baseline lipid characteristics are depicted here. At baseline, median LDL cholesterol was 87 milligrams per deciliter, median non-HDL cholesterol 115, ApoB a median 79 to 80. Note that 92.5% of the patients qualified on the basis of LDL cholesterol equal to or above 70 milligrams per deciliter. This was a very well treated group in terms of statin therapy. In fact, we believe this is truly a maximally treated statin therapy group. 89% of the patients received high-dose atorvastatin or rosuvastatin, and an additional 8 to 9% received low or moderate dose atorvastatin or rosuvastatin. 0.2 to 0.3% received other statins. Approximately 3% received ezetimibe, and less than 1% received no lipid-lowering therapy. They were also receiving state-of-the-art guideline-recommended post-ACS medications for aspirin, P2Y12 antagonists, ACE or ARBs, and beta blockers. The intention to treat lipid levels in dashed lines and the on-treatment lipid levels in the solid lines are depicted here. The intention to treat lipid levels reflect all LDL cholesterol values, including those after premature treatment discontinuation, blinded down titration, or blinded switch to placebo. If we focus on the on-treatment analysis, which exclude LDL cholesterol value after premature treatment discontinuation or blinded switch to placebo, but also take into account patients who had blinded down titration, as well as patients who had reduction in background lipid-modifying therapy, we note that the delta in LDL cholesterol was approximately 63% at 4 months, 61% at 12 months, and 50% at 4 years. The primary efficacy endpoint is depicted on this slide. The Kaplan-Meier curve for the placebo arm shows that this is a high-risk group. Patients who reached 4 years of follow-up in the placebo arm had an approximately 15% MACE rate. The alirocumab arm had a 15% relative risk reduction in MACE, with a 95% confidence interval ranging from 0.78 to 0.93 and a p-value of 0.0003. The absolute risk reduction is 1.6%. Therefore, the trial met its primary endpoint and exactly met its anticipated goal of a 15% relative risk reduction in MACE, the composite of CHD deaths, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. The components of the primary outcome are listed on this slide and are consistently showing trends toward benefit for CHD deaths and a significant reduction in non-fatal MI, ischemic stroke, and unstable angina, the latter three being highly statistically significant. The main secondary efficacy endpoints are listed on this slide in the order of hierarchical testing. Again, the hazard ratios are consistently to the left of the identity line and show a significant reduction in CHD events, major CHD events, cardiovascular events, or the composite of deaths, MI, and ischemic stroke, all highly statistically significant. The 8% and 12% reduction in CHD deaths and CV deaths did not reach statistical significance. There were far many more all-cause deaths than CV deaths or CHD deaths, and the 15% relative risk reduction in all-cause mortality reaches a p-value of 0.026, which has to be considered as nominal given the hierarchical sequence that was pre-specified for analysis. This is the Kaplan-Meier curves for all-cause mortality, showing a 15% relative risk reduction with a 95% confidence interval of 0.73 to 0.98, an absolute risk reduction of 0.6%. Note that both for MACE and all-cause mortality, the curves appear to diverge beyond year 1. Ischemia-driven coronary vascularization was reduced by 12% and was statistically significant. There was no impact of treatment on the frequency of hospitalization for congestive heart failure. We looked at the primary efficacy in the main pre-specified subgroups and found no interaction and in fact a consistent benefit regardless of age, sex, region of enrollment, and time between the index event and randomization. We also looked at the effect as a function of baseline LDL at enrollment for patients below 80, between 80 and 100 or more LDL cholesterol. Note several features. First of all, the baseline risk in the placebo arm appears to be much greater in patients in the third group with an LDL cholesterol above 100. Second, the magnitude of the reduction due to alirocumab was greater in that subgroup, with a 24% reduction compared to a 14% and 4% reduction respectively. Here are the corresponding Kaplan-Meier curves. Note that the p-value for interaction is 0.009. Again, the absolute greater risk in the placebo arm is visible in the placebo curve here, and the magnitude of the reduction appears greater in that subgroup. Given that result in the pre-specified analysis of the primary efficacy endpoint, we wanted to further explore this with a post-hoc analysis of mortality in these three subgroups. The post-hoc analysis suggests that the intensity of benefit appears to be greater in the group with a baseline LDL above 100 or more LDL cholesterol, with a magnitude of reduction of 29%, an absolute risk reduction of 1.7%. Note that the interaction p-value for all-cause mortality is 0.12. If we list the efficacy outcomes in the subgroup with a baseline LDL of 100 milligrams or more, we note a consistent reduction of all hazard ratios with confidence intervals that do not overlap 1. And we note that the 24% relative risk reduction in MACE translates into an absolute risk reduction of 3.4%, and the 29% relative risk reduction in all-cause mortality translates into an absolute risk reduction of 1.7%. What about safety? There was no difference in adverse events or serious adverse events incidence between the groups, nor was there a difference in the frequency of ALT above 3 times the upper limit of normal or creatine kinase above 10 times the upper limit of normal. Looking at endpoints of special interest, the only difference between the two treatment arms were the greater frequency of local injection site reactions, 3.8% versus 2.1%. And this was significant. There was no increase in the frequency of diabetes worsening or diabetic complications in patients with diabetes at baseline. No increase in new onset diabetes in patients without diabetes at baseline. No difference in general allergic reactions, hepatic disorders, neurocognitive disorders, cataracts, or even the incidence of hemorrhagic stroke. So the conclusions of the trial are threefold. Compared with placebo in patients with recent ACS, alirocumab, 75 or 100 milligrams sub-Q every 2 weeks, targeting an LDL cholesterol between 25 and 50 and allowing levels as low as 15 milligrams per deciliter, reduced MACE, reduced MI, and reduced ischemic stroke. It was associated with a lower rate of all-cause deaths, and it was safe and well tolerated over the duration of the trial. Before I conclude, I want to pause for a second and give you a perspective from the executive steering committee of the trial on how to best apply these results in clinical practice. First of all, in this nearly 19,000 patient placebo-controlled trial, including many patients treated for 3 years or more, there was no safety signal with alirocumab other than injection site reactions. And therefore, the balance of risk and benefit for this therapy appears to be very favorable. Secondly, in the subgroup that has a baseline LDL cholesterol above 100 milligrams per deciliter, the magnitude of the reduction of MACE, 24%, and all-cause mortality, 29% compared to placebo, are greater than in the overall trial. And this suggests that these are the patients who may derive the greatest benefit from treatment. Thank you very much.
Thank you very much, Philip. We are going to have 10 minutes of interaction with our experts, and I really appreciate if you answer 30 seconds to 1 minute each of the questions. So I have 2 questions. The first one is, I remember about a year ago here in this meeting, the Fourier study was presented with evolocumab. What is the difference between the results that you presented today with a new approach compared with the Fourier study?
Well, Fourier was a landmark trial. First of all, it was the first trial to demonstrate a MACE reduction with a PCSK9 inhibitor, and there are important similarities and differences between the two trials. I think important differences are the patient population. Our trial tested ACS patients. The Fourier trial tested stable atherosclerotic cardiovascular disease patients. 2 other important features are the intensity of the background statin therapy, which I believe was truly maximal in ODYSSEY, and the length of follow-up, which may be a key differentiator. It was slightly longer in ODYSSEY, with 44% of the patients reaching more than 3 years follow-up, and a median follow-up that was 7 to 8 months longer than Fourier. And that may be a critical differentiator given the importance of time of treatment, as we've seen the Kaplan-Meier curve starting to diverge several months after initiating therapy. The final difference is that while both trials showed improvement in MACE, ODYSSEY outcomes suggests a reduction in all-cause mortality with a PCSK9 inhibitor in post-ACS patients.
Thank you. A second question is, there is a message here that after acute coronary syndrome, we should drop LDL to close to 15, 25, 50 milligrams DL, because it seems to me that that's the way this drug works. And if there is benefit, means the LDL cholesterol that we try to achieve is pretty low. Is this the key?
I believe this is absolutely the key. PCSK9 inhibitors achieve dramatic and sustained LDL reduction. That's how they work. And Further analyses are forthcoming to analyze the importance of baseline, achieved, and relative risk reduction in LDL cholesterol. My prediction is that indeed, as you point out, getting patients to a new target of LDL cholesterol below 50 will be key to improving outcomes in ACS patients.
Thank you. Dr. Sitter-Smith, question?
Thank you. Yes, I'd like to pursue the idea of reduction of LDL for those above 100, and yet the lack of results that you saw in the 80 to 100 group and less than 80. I wonder, this is contrary to the CTT findings and also Fourier, where we see benefit in reduction of LDL cholesterol well down below 80. Why do you think you did not see this? Is it based on your targeting strategy where you changed the dose in certain patients? The risk in that group was lower, but in terms of treatment strategies, we need to know why you did not see a benefit in the 80 to 100 and less than 80 group, and yet did over 100, where CTT and Fourier saw a benefit all the way down.
Thank you. This is a key aspect. I think we have to, I would add two things. The first one is that overall the trial is positive, and the interaction p-value for the relationship between baseline LDL and the primary outcome is borderline. So I think a conservative assessment is that there was benefit overall. In fact, as you saw for the MACE, for the primary outcome, the group that was below 80 milligrams per deciliter LDL cholesterol at baseline derived a 14% reduction in MACE with alirocumab. The second point is that, as you alluded to, there may have been artifacts in the relationship between baseline LDL cholesterol and benefit related to our dosing regimen, which instead of giving a fixed dose to everybody, titrated the dose to get patients into a range, and therefore not all patients in the 3 strata received the same dose of alirocumab.
Thank you. Can I ask Dr. Al-Khatif questions?
Yeah, absolutely. Congratulations to you and to your team on completing this trial. I'm an electrophysiologist, so I want to ask about whether you collected data on sudden cardiac death or arrhythmias during the trial, and whether you'll be reporting on any associations between this medication and those risks.
Yes, thanks to a very careful adjudication process by the CEC, we'll be able to provide more information on the causes of death, and particularly sudden death, and we look forward to that ourselves.
Thank you. Maybe it's time that I would like to see how you respond after this presentation to the following question. Can we have the question in the screen? The question is whether you would change your mind now and you are going to use yes or no based on the study just presented. Fantastic. This is a success of your talk. So, Pat, question?
Congratulations, Dr. Steg, to you and your colleagues on such a marvelously conducted study. I just want to make sure I understand a little bit more about the differences between your trial design and Fourier. Should I have expected a greater relative risk reduction in your composite endpoint because you chose an ACS population and were able to follow them for a longer period of time? It seems to me that the trials are spot on with respect to about a 15% relative risk reduction in either a 4-component composite in your trial or a 5-component composite in Fourier. Should I have expected your trial to achieve a greater relative risk reduction because of what you pointed out with respect to ACS and a longer duration of follow-up as these curves seem to diverge?
Yeah, again, I think that the differences between the trials are key in trying to understanding what we're seeing. In ACS, we know that a substantial fraction of the early events are probably somewhat thrombosis-related rather than truly plaque-related, and the ability of lipid-lowering therapy to affect those post-ACS events is uncertain. In fact, even with statins, there is no demonstration that statin lipid lowering with statins post-ACS affects mortality. So in that sense, we're really very pleased with the result of the mortality in a post-ACS setting. On the other hand, the intensity of the statin therapy we mandated, maximizing statin therapy completely in our patients, may also have hampered our ability to further lower LDL cholesterol and therefore achieve an outcome. That being said, we set out to demonstrate a 15% reduction. That's what we powered our trial for. That's exactly what we found, both for mortality, all-cause mortality, and the primary outcome of MACE.
Thank you. These trials that are international, huge trials, there's always a question about the results in different continents. Were the results similar across the world?
Yes. In the pre-specified analysis, this is one of the items we looked at, and there was no hint of a geographic interaction. Further analyses are forthcoming on secondary endpoints as a function of geography. I have to say that the quality of care throughout the trial, through the efforts of the investigators, was remarkable across the multiple geographic regions.
Thank you. Pamela, do you have any questions?
Yes, thank you. I have a question specifically, again, a comparison with Fourier. We noted that in Fourier there was a very sustained reduction in LDL cholesterol over the course of the trial. And what we're noticing in ODYSSEY is a drift over time, and a pretty significant drift. My question is, we do know that in this trial nearly 8% of patients had, in the treatment group, had the PCSK9 inhibitor discontinued. We also know there's about a 5% incidence of neutralizing antibodies with alirocumab, and then of course the protocol driven itself. So I was wondering if you could comment on that drift and what we might expect in clinical practice.
Thank you. So that's a really important question. So let me get first the neutralizing antibody out of the way. Although it's preliminary data and it might still change, the incidence of neutralizing antibody in ODYSSEY outcomes was extremely low. Actually, the figures we have for the preliminary data, still missing the last visit, is an absolute number of 42 in one group and 9 in the other. So extremely rare. Some of these were neutralizing antibodies, and we looked at the LDL cholesterol in those patients with, quote, neutralizing antibodies, and as has been shown previously in the literature, had no impact on the LDL lowering. So we know from this, as well as from an extensive program with alirocumab of trials, that the LDL lowering effect of alirocumab actually is sustained over time, exactly like the effect of other agents. That being said, we had two things that reduced the apparent efficacy of LDL lowering over time. The first one is that we down-titrated some patients and we stopped therapy in a substantial fraction of patients in the alirocumab arm. 8% stopped therapy and were switched to placebo. Some more patients were down-titrated, and of course that must have played a role. The second aspect is premature treatment discontinuation in both treatment arms. And the third aspect is that presumably for patients who got very low LDL cholesterol levels or because of intolerance, these patients, of whom the overwhelming majority were exposed for the first time to statins at the time of their ACS, in contrast to Fourier, where they were stable on a stable statin therapy, many of these patients may have lowered the intensity or stopped background statin therapy, which explains the fact that the drift we're seeing on treatment for LDL cholesterol to go back up is seen in parallel in the treatment arm with alirocumab, but also in the placebo arm, suggesting that discontinuation or down-titration of background statins in these patients newly exposed to statin may account for some of the apparent loss of LDL cholesterol lowering properties.
Well, thank you very much. The time is over. I'm going to be relaxed now for the next half an hour, and you are taking over. Thank you very much, Philip. Move on.
Are you leaving? No, okay. The next presentation, get your phones out again now because we're going to do another question. The next presentation is on the efficacy of a wearable cardioverted defibrillator after myocardial infarction, which is the results of the VEST prevention of early sudden death. So can I have the question up, please? I routinely utilize wearable cardiac defibrillators upon hospital discharge for my patients with reduced ejection fraction following myocardial infarction. Please vote. Okay. That's our baseline. I'll introduce the presenter of the VEST trial, Dr. Jeffrey Olgan from the University of California at San Francisco.
Thank you very much. On behalf of the VEST investigators, I'm pleased to present the results of the VEST Prevention of Early Sudden Death trial. Like the last trial, the database was closed about 3 weeks ago, and the investigators and steering committee was unblinded just 3 weeks ago. The study was originally funded by the NIH and Zoll until 2012, when NIH funding concluded. After 2012, the study was funded entirely from Zoll through a grant to UCSF. Several studies have demonstrated a high mortality, and specifically a high sudden death mortality after an MI. This decreases over time. As can be seen in both the Olmsted County population trial and the Valiant trial, the rate is highest in the first 3 to 4 months and then tails off. The rate is highest in those with the lowest ejection fraction. In Valiant, there was a 4.4% cumulative 3-month sudden death rate in those patients with an EF of 30% or less. In the Olmsted County study, having a diagnosis of heart failure increased the already high sudden death rate in the first 30 days by 2.5 times. 2 previous studies, Dynamite and Iris, found that prophylactic ICD implant early post-MI did not improve long-term overall mortality. These studies included patients with an EF of 35% or less within 6 to 40 days post-MI. Participants were randomized to either receive an ICD or not during that early period. They also included only patients with other markers of increased mortality risk, such as low heart rate variability in Dynamite or high resting heart rate or non-sustained VT in Iris. Despite not showing overall benefit to long-term mortality, both studies showed a similar trend toward early sudden death reduction in the ICD group during the first 3 months. However, these studies were designed to determine long-term efficacy of early ICD implant on total mortality and were not powered to detect differences in efficacy of preventing early mortality. As a result of these studies, the guidelines for ICD implantation after an MI recommend patients wait 40 to 90 days before being evaluated for ICD implantation. Therefore, despite the high rate of sudden death early post-MI, ICD implantation is currently not indicated during this period. There may be good reasons to delay implantation of an expensive, invasive device in the early phase post-MI. For example, there's competing risk of death from other causes, such as reinfarction or rupture. Or in contrast, a patient's ejection fraction in the ensuing months may improve and therefore may not require an ICD. We set out to determine whether a wearable, non-invasive cardioverter defibrillator, or WCD, was effective in filling this gap in our therapy. VEST was designed to determine whether the WCD reduces mortality due to sudden death in the immediate post-MI period in patients with reduced ejection fraction prior to guideline-directed evaluation for ICDs. VEST is a multi-center, randomized, open-label trial where participants were enrolled within 7 days of hospital discharge for an acute MI and who had an EF of 35% or less. They were randomized in a 2-to-1 fashion to either receive a wearable cardioverter defibrillator and guideline-directed medical therapy or guideline-directed medical therapy alone. Participants and sites were not blinded to the treatment arm, but they were blinded to any arrhythmia detections during the follow-up. Unblinding could be requested if a participant had a shock, cardiac arrest, or syncopal event. Crossovers and ICDs were prohibited by protocol, except ICDs were only allowed for secondary prevention during the follow-up period. Participants were included if they were within 7 days of hospital discharge for an acute MI and had an EF of 35% or less. The EF was assessed more than 8 hours after the MI, and if they underwent revascularization, the qualifying echo was 8 hours after PCI or 48 hours after CABG. Patients were excluded if they had an existing ICD or secondary prevention indication for an ICD, significant valve disease, unipolar pacing, which interferes with the WCD detection algorithms, renal failure requiring chronic hemodialysis, a chest too large or too small for the WCD, if they were discharged to a skilled nursing facility for more than 7 days, or if they were pregnant. Enrollment occurred between 2008 and 2017 in 108 sites from the US, Germany, Poland, and Hungary. The Zoll LifeVest wearable defibrillator was used in the intervention group. The device was available commercially in the US and Germany during the study, and only through the study in Poland and Hungary. The WCD is comprised of an interchangeable garment, self-gelling defibrillation electrodes, dry electrodes for recording EKG signals, and an attachable, rechargeable battery pack and monitor. The device monitors for ventricular tachyarrhythmias and can automatically deliver up to 4 150 joule shocks. A response button can be pressed by the patient to abort a shock if pressed during an alarm that sounds. For both ventricular arrhythmias and asystole, the device sounds a siren alarm as well as voice instructions to call 911 and announces when a shock will be delivered. The device also monitors and records when the vest is being worn by the patient. All data is transmitted to a central monitoring system wirelessly. Participants were followed for 90 days. At the end of the study, the National Death Index was searched for those US participants who were lost to follow-up. Initially, the primary outcome of the trial was total mortality. However, slower than expected enrollment made the original sample size of 4,500 not feasible. In January 2010, after the first 213 participants, the DSMB, Steering Committee, and IRBs approved a change in the primary outcome to a combined outcome of sudden death or death due to ventricular arrhythmia. Pre-specified secondary outcomes of total mortality and non-sudden death mortality were included. In addition, cause-specific cardiovascular mortality and hospitalizations were included as pre-specified outcomes. All outcomes were adjudicated by an independent panel, blinded to group assignment, and without information from the WCD, so as to have parity of information with the control group. The primary analysis was intention to treat, with participants of unknown vital status or indeterminate cause of death treated as not having the primary outcome. A pre-specified sensitivity analysis of these participants was performed by excluding them from the denominator. 2,302 participants were randomized in a 2-to-1 fashion, with 1,524 assigned to the WCD group and 778 assigned to the control group. The mean time for follow-up from randomization was 84.3 days, which includes those participants who died prior to 90 days. 99% of the participants completed follow-up. 10 participants, or 0.7% in the WCD arm, and 12, or 1.5% in the control arm, were lost to follow-up and had unknown vital status at 90 days. The groups were well matched for demographics. The average age was 61 years old in both groups. The WCD group was 73% male, and the control group 75% male. None of these differences were statistically different between the groups. They were also well matched for medical conditions diagnosed prior to the index hospitalization. 35% in each group had a history of diabetes, 65% had hypertension, 25% had a prior MI, 9% in each group had a prior CABG, and about 25% had a prior PCI. 16% in the WCD group and 19% in the control group had a prior diagnosis of heart failure. None of these differences were statistically significant between the groups. The mean ejection fraction during the qualifying echo was similar in each group at 28%. 84% in each group had a PCI during the index MI hospitalization, and only about 1% had a CABG. About 10% of each group had pulmonary edema requiring intubation, were on a balloon pump, or had cardiogenic shock. None of these differences were statistically significant between the groups. Over 85% of participants in both groups received guideline-directed medical therapy, which was not different between the groups. 87% of participants in both groups were on aspirin, 90% in each group were on a statin, 92% on a beta blocker, 87% in the WCD group and 86% in the control group were on an ACE inhibitor or ARB. 20 participants in the control group received the WCD out of protocol. Participants in the WCD group wore the WCD on average 14.1 hours per day. ICDs were allowed only for secondary prevention during the follow-up period. 4.4% of the WCD group and 5.7% of the control group received an early ICD. These were implanted at a mean of 62 and 58 days after randomization, respectively. Neither the frequency nor timing of these implants differed between the groups. Over the course of the 90-day follow-up, the number of participants assigned to the WCD group who wore the WCD each day fell from 81% just after randomization to 48% at 90 days. Similarly, the average number of hours worn per day overall, which included those who wore it for 0 hours on a given day, also decreased over time from 18 hours per day after randomization to 10.2 hours at 90 days. Importantly, when worn, the number of hours worn per day remained high during the study, with 22.4 hours per day worn at the beginning and 21 hours worn per day at 90 days. There was a decrease, though not statistically significant, in the primary outcome of sudden death or death due to ventricular arrhythmia in the WCD group in an intention to treat analysis. There was also a decrease in non-sudden death mortality in the WCD group, but also not statistically significant. There was a reduction in the pre-specified outcome of total mortality in the WCD group compared to the control group. 3.2% of participants died during follow-up in the WCD group compared to 4.9% in the control group. This was a relative risk reduction of 35.5% and an absolute risk reduction of 1.7% in the WCD group. Results from the pre-specified reweighted sensitivity analysis were qualitatively identical. Amongst the non-sudden death mortality types, there was a higher rate of stroke death in the control group compared to the WCD group. There were no statistically significant differences in other causes of non-sudden death. The rate of cardiovascular hospitalization was 22% and was similar in both groups. 20 participants in the WCD group received an appropriate shock. Of these participants, 6 died and 14 survived. 10 participants received an inappropriate shock. 70 participants aborted shocks by pressing the patient response button. The 1 participant in the control group who had an appropriate shock received the WCD outside of the protocol. There were no differences in reported symptoms between the groups, with the exception of 3 categories. Shortness of breath was interestingly more commonly reported in the control group compared to the WCD group. Rash and itching were not surprisingly more common in the WCD group. There are several potential explanations for why we did not see a difference in sudden death mortality, despite seeing a difference in overall mortality. First, it is possible that sudden deaths were misclassified by the adjudicators. There is often minimal documentation and very low autopsy rates. This would reduce power for sudden death, but not for total mortality. In fact, 14 of 20 participants did receive an appropriate shock in the WCD group and survived, which may account for the differences in these small numbers of total events. The WCD may confer additional protections beyond sudden death. It may result in earlier care for bradycardia or recurrent ischemia when manifest by arrhythmias. Further analysis of those 70 patients that aborted shocks are currently underway. The WCD may also reduce anxiety or increase medication compliance due to the physical reminder of the WCD. Nonetheless, more analysis will need to be done to better understand these differences. There are a few limitations to the study. Participants and investigators were not blinded to treatment arm. This may have resulted in, for example, the difference in shortness of breath reported. However, there were no differences in the prescribing of guideline-directed medical therapy or early ICD implantation, which were well balanced between the groups. As mentioned, the WCD was available commercially during the study in the US and Germany, and there were crossovers. 20 participants in the control group received the WCD, and 19% of the WCD group did not use the WCD. This should have biased the results to the null and may in part explain the lack of power in our primary outcome. In conclusion, we did not find that the WCD statistically significantly reduced sudden death mortality, so we failed to meet our primary outcome. However, the WCD was associated with a reduced total mortality in the first 90 days post-MI. Despite a negative result for sudden death, based on the associated lower total mortality, it's reasonable to prescribe the WCD in patients who are post-MI and have a reduced ejection fraction until further evaluation for an ICD at 40 to 90 days. I'd like to recognize my co-authors and steering committee and those who contributed to this study, as well as the 108 VEST site investigators. Thank you.
Thanks, Dr. Ogun, for that fascinating study. I noticed the fairly narrow parameters for evaluation of ejection fraction post-MI, post-PCI, and post-CABG. Could you comment on how the steering committee chose the timing of evaluation of EF in the study?
It was chosen because patients are being discharged from the hospital very quickly. So we initially had a 24-hour period at the very beginning of the study. That was changed to 8 hours because people were being discharged within 24 hours after PCI. We were losing a lot of patients. As it turns out, our mortality in the control group is really no different than the prior studies. We had a 4.9% total mortality in the control group. So I'm not sure that that narrow window makes a whole lot of difference in terms of the increased risk during that 90-day period.
Thank you. Dr. Wilbur.
So thank you very much for these really interesting data, and I think clearly to flesh out your last comments and recommendations, I'd ask for some clarity. And some of this really surrounds the relatively small absolute effect of the device in this large population. And so the question obviously comes up in a subgroup of patients where there's a little higher risk. Might that that benefit be maximized? Obviously the cost of the device, the therapies, I think averages around $10,000 for a 3-month treatment. And so one of the questions clearly becomes, is there a population that would benefit more than others, and have you done that subgroup analysis or plan to do it?
We plan to do it. We have not done it yet, but we certainly have that. We also have the cost data, so we'll, on the list of things to do early is a cost analysis of this as well.
And then a second question, I guess, is that one of the questions, again, is the number to treat, needed to treat and that sort of thing. That obviously will come up. It is concerning that, that by the most obvious mechanism of reduction of sudden death or documented tachyarrhythmias, that there was appeared to be very little benefit, yet we still have, in the combined analysis, a difference in mortality. Are there other, you presented a couple of possibilities for what might be going on. Is there any other potential explanation that you can come up with? The other two didn't seem very plausible as a potential mechanism.
Yeah, I mean, I think the main reason is that, you know, it's a relatively low event study, right? We had, you know, 3.5% and 4.9% mortality. And so any small number of misclassification of sudden death is going to dramatically reduce our power to see a difference. So I think that first bullet point is the main driver. We are doing a full analysis, we haven't done it yet, but of all of the shock events and all of the people that have aborted shocks to sort of see what has happened to them, but we don't have that data yet. I think that's the most plausible explanation. That said, I would not discount the benefit of being monitored post-MI and picking up things that may not be tachyarrhythmias. So bradyarrhythmias, the device detects bradyarrhythmias, and perhaps people went and sought care earlier. We don't quite understand why we saw a difference in stroke deaths. Perhaps, you know, the neurocardiogenic axis produced some non-sustained arrhythmias that got people to go to the hospital earlier. All speculative, but all data that we'll be analyzing.
But you did say that in general, I think as far as follow-up and there being potentially more close follow-up, that patients who had received treatments from the device and that sort of thing, that information was not passed on to the investigators to alter their subsequent management. That's
right, but it was passed on to the participant, right? Because there's these siren alarms that went off. Patients were pushing buttons to avert a shock. I don't know if you've heard any of the alarms, but they're quite alarming.
Have you had an opportunity to evaluate that in any way to see if the subsequent therapies varied, hospitalizations, that sort of thing afterwards?
We've looked at hospitalizations, and I showed you that. The hospitalizations were the same in both groups, but we haven't looked to see exactly what happens to those subpopulations that had either appropriate shocks or aborted shocks. Those are all planned.
Dr. Al-Khatib?
Yes, of course. Congratulations to you and to your team on completing this important trial. So you did not show us sample size calculations, and I can't help but wonder if you ended up with a lower event rate related to the primary endpoint of sudden cardiac death and arrhythmic events. And so the question to you, especially if you look at your patient population, actually, this was not a sick patient population. About 42 to 46% of your patients had New York Heart Association class 1 symptoms at baseline. And a distinct minority...
Pre-infarct. Those were baseline coming into the hospital before they were admitted.
Right. No, I understand that. Okay. And then a distinct minority had not had heart failure before, had not had an MI before. I mean, a distinct majority. And so I wonder if you ended up with a lower event rate than what you had initially projected or anticipated. What was your projected rate vis-a-vis the rate that you ended up with?
So interestingly, the rate was exactly the same. So again, we used Valiant Ephesus to calculate our event rate, and our total mortality event rate that we assumed was 5.0 in the control group, and our event rate in the control group, in our control group, was 4.9%. And we estimated a 35% reduction in mortality in the WCD arm. So our event rates were right on. What was lower was our anticipated percentage of people in the WCD arm that wore the WCD. We had estimated only 10% would not wear the WCD, whereas we were closer to 20%. And I think it was that factor that drove the decrease in power for our primary outcome, not the event rate.
And do you have any data on how many deaths occurred when people in the WCD arm were not wearing the vest?
Yes, we have the data. We have not analyzed it yet.
And finally, in relation to inappropriate shocks and aborted shocks, do you have any information about the risk of AFib with RVR that may account for the difference in stroke risk between the two arms? Perhaps if I'm a patient and I aborted a shock, I went to my physician, they diagnosed me with AFib,
right.
They started me on an oral anticoagulant, my risk of stroke is going to go down significantly. Do you have any information on this?
We will. We do not now. But we have all the monitoring data, and as you can imagine, there's a tremendous amount of monitor data to go through, so it'll be months to get through that stuff.
Because from my perspective, if it's only the monitoring, I wonder if you were to do a trial comparing a vest with implantation of a loop recorder, what the results would be. I mean, that would be an interesting trial to consider.
Yes, agreed.
So let's see what the audience thinks if you've changed our minds. So get your phone out and let's put a question up. Did the data presented in the VEST presentation change your practice?
Oh, wow.
Okay, no change. But I'll give the last question to Dr. O'Gara. Has this changed your practice?
Thanks very much. And Jeff, congratulations to you and your co-investigators for bringing this forward. I can only infer that the length of time over which enrollment occurred meant that perhaps there was a lot of off-label use of the WCD and difficulty in randomization. But I just wanted to push back a little bit on your last concluding bullet about the use of the phraseology that the WCD would be reasonable. And that would kind of elevate things to a Class 2A indication. And I just wonder whether at this early stage, not having met your primary endpoint and being uncertain about this signal of association with a reduction in total mortality, we would think of it in terms of the usefulness is uncertain.
So it already is a Class 2A indication in the most recent guidelines based on other data that's come through prior?
Correct. I'm just asking you if you would consider a change in that phraseology.
Oh, I see. You're asking whether this data would elevate it?
No. Would actually reduce it by virtue of the fact that the utility is uncertain compared against there is a reasonable benefit.
I think it's hard to ignore the total mortality data, and given the caveats of adjudicating sudden death, I think that in combination with the previous non-randomized data that's out there, it seems reasonable to keep it as reasonable, given the totality of it.
Understood. Okay, thank you.
We'll end on that note. Thanks for joining us for the opening showcase, and please enjoy ACC 18. Have a wonderful meeting.
Thank you.